tumor immunology and immuno-oncology has blossomed into what it is now, and have been really fortunate to be at a place like Stanford that really values and kind of fosters this opportunity of really directly translational work. So that's where I found myself for the first decade of time as a faculty member, running clinical trials in the translational research space for patients with brain tumors. So I'm a neurologist and a neuro oncologist clinically. But the more I did within my clinical world, the more I realized how much I loved medical education and how much I have learned, throughout my personal journey. Being kind of first gen, my parents immigrated from El Salvador and India, met in LA, and but navigating higher education was always something that I found kind of fascinating from personal experience, that I loved being able to bring back to students who had similar paths and needing to navigate higher education in the US. So that is kind of what motivates me and my background, and thank you, Jonathan, for having me.
Was it a change in career, or actually they're all interrelated, it all comes together?
Yeah. Significant change in my career. So, when I first started, I did become a fellowship program director for Neuro Oncology, which is a tiny niche within, so we typically had 1 to 2 fellows a year, did that for 7 years, and then became an associate dean in our medical school 4 years ago, and was overseeing a lot of program building in that space. And then when this opportunity, our dean, brought to my attention, I really did have to pause and think, because this is an 80% role for me now. I had to step away from clinical duties. I had to step away from some of the grants, many in this room are aware. Olivier, I had to have a conversation with Olivier that I've enjoyed, being a clinical partner, but I have to step away from some of the grants that I'm not leading, but contributing to. So in order to make space for a role like this. So actually, for background, EPS, which is our Education Program Services Unit, is multiple hundred staff, 100 faculty, teaching faculty. It spans our UME, so medical school, GME, residents and fellows, and CME actually is also within that umbrella, Lane Library. So many different teams to oversee, and I've really enjoyed doing that. Yeah.
Fantastic. Well, let's go ahead and dive in.
Yes.
I'm sure we're going to sponsor a lot more discussion.
Yes.
Here we go.
Okay. How are we?
Fantastic.
Okay. So getting back to why I'm here and the interface with you all, and how I kind of began this conversation with Jonathan in particular, is this concept that, we're at this really unique moment in medicine where, as you all know better than I, AI is changing everything, has the capacity and is changing everything that we do in terms of efficiencies, but also the actual clinical diagnostic and therapeutic process, and has the potential to really change medicine in the most profound way that I've seen in my lifetime, certainly. And I wanted us at Stanford to really meet that moment. I think so many teams across our university and our medical school have been focused in this space for so long, and yet I was surprised to learn that when I took on this role 3 months ago, August 1st, one of my first questions was, do our students learn anything about AI at all? Is there a single lecture? Is there a single course? Is there a single slide that incorporates artificial intelligence into our curriculum? And the answer is no. And that was kind of a aha moment for me to say, pause, let's time out for a second. All this great, we're in Silicon Valley, our students, if you read their profiles, we put together a profile book on our entering class, and about a quarter of them had something related to artificial intelligence in their background. So they are coming in, choosing Stanford for this reason, and yet we haven't really met them where they want to be and where we believe medicine to be going next. So how do we truly integrate AI into the nexus of medical education? And so today we'll kind of discuss, and I really want this to be a bi-directional conversation. The creation and integration of AI in medical education. We'll explore strategies to foster, truly what's near and dear to my heart too, the physician scientist career development pathway, which is core to our mission here in our medical school. And then again, I'll kind of come back to this reflection on my transition into this leadership role. And for those who might be interested in medical education, this is an open welcome and invitation to do so. So right now, we recognize this changing landscape, the new technology. We would love to be able to recognize how interdisciplinary what we do is and embed that somehow in our approach. We recognize this kind of toggle between academic and clinical duties and responsibilities. It makes us oftentimes a little more spread thin, and this is where the efficiencies of the technology can help us in theory be better clinician, better physicians, better poised to really contribute to academic medicine in the best way possible. And we really want this to be an approach that is adaptive to our learners too, and responsive to our educators as well. So this is an AI generated picture, and I really typed in AI and medical education curriculum, and this is what ChatGPT spat out to me. But I'm not saying we're going to be there, in the next year. However, I do fundamentally believe things are moving towards that direction. If any of you all teach any of our lectures, you will see the majority of our medical students will have their laptop out and will be kind of typing away as they're in class. And honestly, this is so different than even when I went through medical training, right? A couple of decades ago, this was not the norm, and yet it is now. So we have to really recognize that we are changed from the traditional lecture mode of what medicine and medical education used to be. We really, recognize the growing influence. I think this room does not need to be convinced around this, but diagnostics, personalized medicine, clinical decision support, and also just the learning process around literature summaries, predictive analytics, patient outcomes. So we need our students to be proficient in the language, in the core values, but then actually I think it goes without saying that our faculty development component is also very real, and possibly where there's and I would put myself in that bucket where more support is still going to be needed. So how are we going to approach this? This is a framework. This is not, as I said, I'm not the content expert. You all are, but this is how I approach anything and how I have approached anything within the medical education space. We really need to think about what our critical content is, and this, incorporates the core AI competencies, promoting the early clinical application of these competencies, enhance our clinical decision-making skills using these new technologies, cultivate our physician scientists. And actually, there was a really robust working group that was focused on this that some in this room were contributing to as well. And I think it goes without saying, but I think I want to just make sure to highlight it here, that the social, ethical, legal ramifications are significant. And we want our students to be well appraised of what these are and how to best be conscientious and cautious users of the new technologies as they come out. And then we'll obviously be adapting and evaluating in real time along the way. So what are our next steps? We're gonna create this, curriculum framework, the instructional materials. I would love to be able to actually launch this as we're also doing a curriculum redesign of our undergraduate medical education to launch initially next fall, so fall 2025. So we want some of this content to already begin to emerge within our lectures, our cases, our assessments. Interestingly, we're not alone in this, but the AAMC I have been engaging with very closely is looking to us to kind of be a shepherd and leader within the academic medical space. And this concept of Stanford's playbook as being scalable across the country throughout our medical schools is very much something that the AAMC is hoping, which is our American Association of Medical Colleges, is hoping for us to lead in. And so we're also going to be self-reflecting on the faculty development training component. Yes.
Yeah, so I've been involved in some of these conversations, and it seems to me that one of the barriers is that their curriculum is so set and so packed that there's no room for any of this. So do you see that you're going to integrate this into the existing material, or is it going to be a separate material, or how have you thought about that?
I think I've thought about this as a 1.0 level, 2.0 level, 3.0 level, and Nigam has heard this already before. So I do think all of our students have to have some content. So, beginning with orientation, we need to, carve out time to ensure the first year entering class knows X, Y, or Z, right? Yeah. Second years, we need to meet them at a different level because they would have taken some content, but also want to kind of help them get to their clinical stage, right? But then for those who want to go to that 2.0, 3.0 level, those who want to do a scholarly concentration, which is the term that we use to carve out those who want to, focus and have some scholarship in this area or what have you. And then the 3.0 level, we have MSDP and MD PhD students who want to focus on this, throughout, and having you all serve as faculty sponsors and mentors is going to be key for those types of students.
And the other sort of challenge with this is that what we need to teach keeps changing every 3 months.
Absolutely.
And so even if we look at the rotation structure of medical training, by the time the 4th cohort comes into rotation, what we would tell them has changed. So which would make us appear quite inconsistent, what we told one part of the class versus the other part of the class. There's a very interesting challenge in terms of curriculum design.
Absolutely. It's not a stagnant content. And ironically, that part is not new in the sense that the content of medical school has exploded in terms of the necessary information needed to be acquired in such a short period of time. That, and to your point, we pride ourselves in not being a school that teaches to the boards, because the boards tends to be the slower glacial change. But we recognize that this content still needs to be learned. The fast-paced nature of change, though, is going to be a challenge that is different than any other, right? Even in kind of the precision medicine, genetic analyses, those have not changed at the pace that this is. And yes, we're just going to have to continue to iterate. I will say this though, that our hospital system, we're well positioned because our hospital system and our School of Medicine being kind of on a unified front, that this is a huge priority, has built-in resources to ensure that we are able to meet this moment well. And actually, that's very unlike other things in medical education, where we're actually more on the same page than not. Yeah.
The other interesting challenge here is this is a general purpose technology. We don't teach MD students specifically about electricity, about Excel, about driving. And so today we might have to teach stuff, but maybe in 3 years, the incoming class will be proficient enough that we don't have to teach anything.
I think you hit on such an important point, because I would not underestimate the fact that our faculty have to be taught much more minimum basics than our students coming in, especially those types of students that we tend to choose here and choose us as well. They are much more proficient at the get-go, but it's also not every single student, you know, and we can't make assumptions that baseline knowledge is no.
But I think it's, I mean, so yes, technology is changing, it's become more integrated, but understanding like the societal harm, the implications, that's not changing that rapid. Those are some basic core principles. Understanding how to interpret an output, not how to develop an output, not how to develop the model, but how to actually use it and how to think about what it's asking. I think those are like more stable blocks that could be built on that year one.
That's true. So actually, this touches on what we were just talking about, that it is very much a collaborative approach. You know, the curriculum development content, of course, is one, the aligning with our learning outcomes, but there is a lot of expertise that is happening across our universities that we're really unique to have, right? Between our engineering school, our school of education, and also the hospital system and the School of Medicine. There are many, in many ways silos, but also in many ways like collaborative groups working in this space that we're very unique to have, right? Most medical schools don't have this shared campus, shared approach. And then of course our technical support teams in the hospital, which many, you know, are leading, are really on the same page, and we're having these conversations together. So what are our next steps? We are in the final stages of solidifying the faculty champion for AI curriculum integration search, or AI curriculum integration. We are going to be building out, announcement to be coming soon around that. We're going to build out a steering committee of, you know, experts in their own unique niche and space that want to help and support, and we want to help and support to ensure they have the protected time to focus on the educational components around this. They're going to be working with our curriculum and assessment teams that already exist, you know, within the Education Program Services Unit, the TDS team, Technology and Digital Solutions team, and aligning timing wise with our curriculum redesign, to Tina's point, to make space in the existing curriculum for this core content to be possible. So maybe I can pivot, but pause if there are any questions for now on this topic. So for me, you know, I've been seeing these technologies show up first within my scientific kind of hat that I wear. And so, you know, my goal really, and our mission as a medical school is really to foster this career development of physician scientists. And so I think this is really unique in that we're trying to bridge this divide between clinical care and research and bring these discoveries from bench to bedside. And this area actually allows that, I think, union to be more facile. And obviously there are many, many different domains of research that can be impacted by the new technologies that we're seeing. And we recognize that our students share with us the challenges of the physician scientist pathway of balancing their responsibilities, funding, mentorship. But this kind of also, I think, helps us to manage burnout. And so addressing these efficiencies is going to potentially help unlock time for more physician scientists to do the work that they want to do. So we're going to be building out these structured mentorship programs, protected time, and skill building workshops for those who want to focus in this space of AI in medicine, and make sure there are, you know, mentors that are helping to shepherd our students to pursue careers in this space. So, I already began with this, but a few pictures help to share the story. I, really began my work in the lab setting, and it's been such a wonderful journey to be able to work with this amazing team across neurosurgery, medical oncology, bone marrow transplantation, and treat the first patient in our adult hospital ever, with a solid tumor with CAR T cells. So CAR T cells are chimeric antigen receptor T cells. They're part of our immune system that is genetically modified to become tumor specific. And the tumor of my, interest is glioblastoma. And so this team approach has really led to a lot of amazing discovery and scholarship within this area of research. What motivates me here is this grim reality that there has been very little progress in the treatment of patients with glioblastoma. This type of tumor is extremely aggressive because of the way that it grows and infiltrates into the normal brain tissue, and it actually makes surgical extraction and also even radiation and chemotherapy does not help to address the single cells that remain behind. I give this analogy to my patients that glioblastoma grows like a tree, and the roots are somehow very difficult for us, despite so many advances in medicine, to target and eradicate. And so this T cell approach is intended really to go after those isolated tumor cells that are left behind. So our patients actually have this procedure where we extract their blood, take out their blood immune cells, their T cells, and then genetically modify them to become tumor-specific T cells. And then our team injects these T cells directly into the brain through a reservoir called the nomaya. So in this world, I have seen, the innovations of AI to actually gather this incredibly rich data content and hopefully in the future allow us as a goal to be able to predict who are the early responders, who are the non-responders, who are the, patients that we should pivot to another therapy first in. And so, this is my only other hat that I have kept while still being, within this new role as senior associate dean of maintaining this CAR T cell program and treating patients in the hospital and those that, are in the outpatient setting as well. So far, and actually, this is homegrown research at Stanford. So these CAR T cells are actually manufactured right here close by on Page Mill at our cell manufacturing facility. We're gathering a lot of correlative science because we're sampling their CSF fluid, which is the cerebral spinal fluid, from them as they're going through treatment all along the way. So we're getting day 1 samples, day 3, day 7, all throughout their 6-month journey in treatment, and just gathering so much data that we can now begin to analyze as to who are the best early responders. They're the MRIs. And I mention this because as we pause, in the past, we would all be kind of grappling with all this data is, we can reflect on, but we can't actually bring together under a few cohesive questions. And now with the powers of AI, we are hoping to get to that point in the near future. And then the last part of this conversation, really, I wanted to just share some reflections on what I've observed in this kind of transition to my, role within medical education. And what I've really loved is this kind of threefold aspect of overseeing curriculum design, implementation, mentorship, and working with faculty, and really addressing how we are trying to promote this inclusive and well-being in our learning environment. And I share this really because I'm hoping to motivate each of you to consider, putting on your educator hat. We're in such a rich environment like Stanford Medicine because of the learners that are also in our midst. And, they would love to hear from you all, hear about the research that you're doing. And so I, again, welcome you to be, to reach out to me and to be thoughtful about how does what you work on, how could that appear within our medical education curriculum in the future? And so, for me, it's been also balancing those priorities that I find kind of core to my work in academic medicine, administrative, teaching, personally, building those collaborative networks, and then embracing that change is always in our midst. So maybe actually with that, I might pause to just say, these are the practical takeaways. We're going to be integrating AI into medicine, into the coursework. As we're thinking through how to do that, we want to build this career development pathway for students and trainees who want to devote their time and their future research in this space. And then again, welcoming those because this is very an important collaboration with you all that I, overseeing these programs want to be able to facilitate this. So, and then an outfit.
Open up for discussion or questions, comments?
I'm going to get started.
Yeah.
Because one person talks and then everybody wants to talk, right?
Yeah.
So where are you getting started? I mean, what do you see as the low hanging fruit that you're gonna go after?
That's a great question. I think, first off, I recognize this is not my area of expertise. So where I want to get started is resourcing the individual team that is going to focus in this space to have the obviously ability to license products that need to be licensed, bring our assessments into this space. There are a lot of learning tools that are coming on, vendors. I get emails every week from vendors who are hoping for Stanford to put their name on their, marketing material, to be able to teach content, to be able to have like a learning platform for our students to engage with. So I want to be like, that's what I see my role to be. It's to open those doors, bring down those barriers and, but not to necessarily come up with what the key specific learning objectives should be, because that's not my expertise.
I'm thinking about a lot of the development. Physician scientists is great. Most of the people in this room actually are not physicians, right? But they are very interested in the applications and problems. What are your thoughts on how do you foster those effective collaborations across actually pretty wide cultural differences in terms of what people understand and expect?
Yeah, I've noticed actually along the way that as our footprint, our geography of Stanford has spread out, those natural connections, and especially now in this post-pandemic world on Zoom, those natural connections don't easily happen. So those, I'm thinking back even like Olivia, some of the time, the ways that we've actually interfaced have only been when there are in-person research venues or in-person community gathering events that enable those natural conversations to say, oh, you're working on this, so am I. I would love to think through what you might be interested in. So maybe this is another way to incentivize the folks to join the learning environment and the teaching environment, because our students, we have 90, medical students, we have over 1,300 residents and fellows. They're constantly looking for mentors to engage with and also to work on projects with. And that might be a great way to ensure that within this space, we are, and this is where I can be helpful, facilitating conversations to happen between this campus group and our main campus students and our trainees. So I don't know if that helps. Yeah,
But you know, Reena, mentorship takes time
Yes.
on both sides,
that's
right?
true.
And so, I mean, I think it's important to think about the protected time or the benefits or something for both sides, right?
Yeah.
Because like in this room, I'm sure everyone gets at least so many students knocking on their doors
Really?
for help with expertise, as Jonathan said, you know, most of us aren't clinicians for the application, and
Yeah.
so that has to be thought out, you know, how do you balance that or make incentives for people who are not support staff, right, but really building a career and that combination.
That's a great question. So what I'm hearing then is providing funding opportunities, providing mini grant opportunities.
yeah.
Because what we do have already currently is, for example, our Med Scholars Program, right? So it supports, and very unique to our medical school, by the way. This is not normal, you know, across the country, where we actually fund students to have dedicated time, both 100% time during their summer months between first and second year. That's typically 8 to 10 weeks of a dedicated student who is highly motivated to be productive during that time, who can actually join your research team and, you know, have a mini project to work on. Oftentimes, and this is not necessarily well known, but oftentimes those students who choose a particular lab to join for their Med Scholars first summer end up wanting to work with that faculty member long term, you know. So once you get that student in the door, in a way, they oftentimes want to engage with you for the duration of their time as a medical student. And we, School of Medicine, pays them to be a free kind of student or, you know, assistant lab, you know, member with you, with your team. So that's one, but then I also think like if we can, and I would certainly be open to this, think about like a mini grants program.
Yeah, so we get,
so that-
right, the Med Scholars funds the student, but the faculties are donating their time, right? So something like that would be interesting.
Absolutely.
I want to just start with a compliment. I think it's a generation ago, physicians, I think, thought of themselves as, you know, sitting with 3 legs on a stool for both the clinical, the scientific, and for the educational portions of the job. But today, that's virtually impossible, as we all know. And you seem to be an example of someone who's learned to ride the unicycle on all 3 of them, on all 3 spaces, which is pretty impressive. I'm curious, as you're like appealing here to this group for how do we get more help in the education mission from the research side? How do you address burnout with AI?
Yeah.
Is that something you've thought about, and does that play a role in the educational portion?
Yeah.
Rather than asking people to do more and fit more into the curricula,
Oh, absolutely.
is there a way that we can do less and actually fit more time for holding the patient's hand
Yes.
and being there and improving that interaction?
This is a conversation that we, you know, I've been a part of, not leading, but a part of with the hospital system. Because it is absolutely true. I could see 2 different things happen. So as we have ChatGPT, you know, the Stanford version, prep the patient response to their questions and inquiries that we get every day as physicians. The thought is, okay, now you're gonna free up more time to see more patients, you know? And actually, to your point, what we need to do is say, this work didn't even used to be part of what you were expected to do a decade ago, 15 years ago. And so, you know, we had moved away from holding the patient's hand and spending that time at the bedside. And now that we provided these efficiencies, we need to go back to protecting that time for engaged clinical, you know, work. Same is true for note, you know, creation. You'd be shocked at how much time we spend. Oncologists are I think the worst, you know, we have very detailed notes, and those take so much time, but time away from the time we have with our patients, you know. So I'm hoping that many of the advances to the technology we'll have in like note creation, et cetera, are not going to just mean that we're gonna fit more patients into our schedule, but actually the reverse, actually make sure that that time is still protected for engaging, seeing a patient eye to eye and physically taking your eyes away from the computer to like talk to a patient.
So two here, and then I have one on, go ahead, maybe, yeah, go ahead.
Oh, okay. So building on that, I think there's a side to that comment that, you know, when you think about the interactions that AI is gonna have eventually with patients, the interactions that then, you know, currently training physicians are gonna have. I feel like there is an opportunity to start to teach medical students about what you view as the most important essence of being a physician. And, you know, in the sense that AI is gonna do a lot more increasingly. I mean, there's probably AI systems already out there that are probably smarter than a medical student, right? And so,
Exactly, some of us in the room affirm that with us like studies.
exactly. So I think that if I was a first year medical student right now, I would be grappling with the fact that I am, you know, am I racing AI right now? And I think that there's an element to the early years, and you talked about these various phases, those early years, it's critical. What makes you special in terms of your role as a
And I think what makes us special is that human touch. You know, I personally believe that no patient wants to only engage with a chatbot to come up with the right diagnosis. I can certainly say that is true on the oncology side. That where that journey that a patient is taking, I can feed them as much content, educational content about what the chemotherapy is, but they still want to see me. They don't even want to see my fellow or APP, they want to see me. And that is that personal touch that only humans can provide, that to your point though, we have to continue to build that muscle within our students, that this is your unique added advantage that AI cannot replace. And that doctoring, that compassion, that empathy, you know, is still going to be important to emphasize, while everything else is going to be technology driven in theory. Yeah.
We're going to follow on to that one, and then I'll go to you, Stephanie, in a sec. But how much curriculum is there in med school right now to like train those aspects of human medicine, or do we just give people multiple choice exams all day?
No, so we have a course called Practice of Medicine. So the practice of medicine is exactly that. It's longitudinal, it's throughout their entire, you know, medical curriculum, where they are learning doctoring. They're learning how to engage. We actually have an amazing sim center in the ground floor of the Lee Cushing building that videotapes our students engaging with standardized patients, and then, you know, with kind of model scenarios, clinical scenarios, to actually assess their ability to be compassionate and to communicate effectively in that space. And those are skills that actually are educators for care. That's the group of faculty educators that help to facilitate and teach. Really important skills.
Stephanie, and then I have a couple questions online.
Yeah, two sort of questions for you. One of them is more of a clarifying question of like, who are the stakeholders that you've engaged in this so far, and who are you considering? That's my first question, and then
So far, it has been, I don't know, I started off with one-on-one conversations with about 20 people, somewhere in that order across campus, at the university, some in this room, who hold leadership positions, or lead, you know, big programs and institutes, kind of focus in generally this space. And that helped to inform, because again, I was a novice in that, like, I knew this is something we needed, but I didn't even have the knowledge as to where things currently stand within our landscape. And that helped to inform this approach that we've taken in terms of like, what will our strategic plan generally look like? And then of course I went back to our dean and said, okay, now I kind of understand the lay of the land. Can you help resource what we might be needing, and that's the approach that I've taken. Actually, one other thing, this did not begin with me either. I think I want to give credit where credit is due. There was under the prior senior associate dean, Neil Gesundheit, there was a task force that was put together of various different leaders, again, both within the education and curriculum space, but also within the, let's just say, data science space, to say, what are the key learning objectives? And I think they put together the 6 that I listed on one of the slides, of like what we want to make sure we cover. And that, again, is kind of what has helped to inform our next steps.
Yeah, part of why I'm asking is because I do a lot of research with residents and trainees around assessments within medical education. And so it's always interesting to come to these sort of sessions because you get the faculty side and then you get the, the trainee side. And so I guess a couple things that I would just have you think about in terms of stakeholders is I know often we will have student representation, but this might be a place where we actually want more student representation than we typically have had on committees and things like that.
Yeah.
I also work as the PFAC faculty liaison for the emergency department. I'm in emergency medicine. And there's actually like a lot of folks, like patients that are very,
Patient
retired,
advocates,
retirees and things like that, that are saying, how come my phone can't do this? And I'm like, we're working on it. Like, that's my party line. But I think in terms of being smart, strategic, like we were talking about funding and things like that, like we actually have, I think, a deeper network here than we give ourselves credit for sometimes. So that's just some like low hanging fruit in terms of people to perhaps tap into. And then my second question was going to be about like the curriculum. Are we thinking curriculum redesign or are we thinking like curriculum augmentation, I guess? And the reason that I sort of asked that is because you brought up the example of notes, which I think is a really great one. As an educator, do you still have to now teach someone how to write a note, or do you have to teach them how to be able to edit a note? And does foundational knowledge become more like, these are all questions that, it's not a, there's A, B, and then the imaginary C that we haven't thought about yet.
Yeah.
So I was just wondering in terms of like some of these task force and groups and committees and stuff that are working on it, is that stuff still being sorted out or? What's the plan for that?
Yeah. Okay, really all great points. For the first part, we again are so unique as a medical school. I keep saying that, but it is true that we fund our students to be curriculum development assistants. Because we want to support students who want to be future educators as well. And so this is not unique to this topic. We have had students in the past who sit on committees and contribute their knowledge and skill set as educators. Some of our students who have done this amazingly well have been prior educators themselves. They have come in with their doctorate degrees in education and, so they know the, actual content of being an educator, a super educator. So we will certainly put out, actually, even on the search for this role, we had students engaged in that process. So they, put up their hand and volunteer to be part of the search kind of committee process and will definitely be engaged in the content creation as well. That's first. Second, gosh, there were so many. Let's see. Patient advocates. I love that idea. And actually in oncology, we really focus on that because the patient experience is so critical to the success of any kind of innovation. So I had not thought about that before in this space, but I agree. I think that's a great idea, and we should think creatively as to how to, facilitate that. And then,
It was about the curriculum. I was just gonna also say that, this might be also a good opportunity to bring together different levels of trainees. 'Cause I think a lot of times, like, I'll give you an example. When I ask a medical student, hey, what are you doing? They're like, I'm doing everything. When I ask a resident, what are you doing? They're like, I'm doing nothing because it's the team that's doing it. So somewhere between being a medical student and, becoming an attending physician, they learn that, right? And I think if we ask them in their silos, they often don't know what they don't know.
Yeah. Definitely. But actually, with regard to the redesign, so that also predated this work. So, our school has actually not done a curriculum redesign in 14 years. And so this is being planned anyways. We're gonna be actually shortening just slightly, by a few weeks, our preclinical curriculum to allow for, and this is just a national trend, within medical education, to allow for earlier clinical, exposure. And so this is an opportune time to, shave off the things that are unnecessary or need to be updated, i.e., how to write a note is going to be, in theory, facilitated by some of these new tools. So yes, we want them to know the fundamentals, but yes, we also want students to know how to use the technology. Very much another very separate but important priority of mine was unifying our EPS unit across UME, GME, CME. So this is, again, not unique to AI or this topic, but that has been a huge shift to the culture of our unit from the past. People previously were operating in very much in silos, but for many different reasons, I'm bringing these groups together more on a regular basis. And this is a topic that I agree will engage our residents and fellows along the way too.
Actually, a couple of questions online I want to get to. April Liang, one of our clinical from Maxwell, if you want to take it. And then Gil Bejarano after that, and then if you'd like to look after it. April, go ahead.
Thank you. Thanks for speaking, Reena. Some of the other questions touched on this, and your example about the clinical notes is kind of one that's top of my mind. How do we think about the de-skilling that happens automatically as a part of new technology and adoption? Thinking about, is writing a note a core skill for medicine, and is that a way we synthesize and think about problems? But just thinking about how would you, with this new curriculum, think about that, define what things should be de-skilled and should not, and also how do we measure how much de-skilling is happening?
Yeah, and actually an analogous scenario is something that I've seen happen, right? So during my clinical training, I was writing all my clinical notes. There was no electronic medical record. And our ordering system was all handwritten. Our prescriptions were all handwritten. I had not looked at my prescription pad, I don't even know where it is anymore, right? So it's very true. This is not new territory of skills are fundamentally different in just a few decades. And so this is going to be very akin to that. I will, want to pause for a moment to recognize though that we are still wanting to prepare our students for medicine in all locations and in all venues. So even though the Stanford GPT has the ability to prime our nodes and has the ability to prime patient responses, not every hospital system is going to have that. And unfortunately, this cohort of students are going to graduate into a world that is heterogeneous. And so they do have to have both skills. But I want them to be prepared for scenarios of working in rural, America that still actually even has handwritten notes, so they need to know all of the above. And to your point though, it's asking a lot of our students. And I think that's the reality of today. In some ways we are asking them to know more, and in other ways we are also giving them the tools to access resources in a way that I didn't have going through medical training.
Gil Bejarano, do you want to jump in with a question online? And then we'll go back to the room.
For sure. Can you guys hear me well?
Yeah, go ahead.
Awesome. Okay, so I wanted to, just remind us of the script that AI will likely not replace people in the workplace, but people not working with AI will be replaced by people working with AI. So, right, that's just so relevant here. It seems to me that you could start educating clinicians to work with AI right now without even any AI. You could, right? So you would be a fool not to listen to an AI that's good enough. And you would be a fool to take AI at face value because our AI still makes mistakes and it makes them in a very weird profile that's not like a human profile. So just one example to give you, there's many of them without anchoring on any system because as you wisely said, the systems move so fast. You can take any pen and paper that your students exam that your students are taking now, and you add a bubble next to any question, which is an AI suggested answer. But of course, you write that answer. So you sneakily make some of them spot on, some of them wheezy, and some of them completely off mark, and you just get them used to work with another voice that is good to hear to, but not good to get addicted to. I think you could start that training today. Maybe you've already started. I don't know.
Many teams have already started in our hospital system. But like I said, even though that has started, our classroom instruction has not yet been touched with this content.
So like I said, you don't need an actual AI deployed for that. That point I made clear, that's the only point I was making. You could start it today. Just add suggested answers to every question you ask. For example, any scenario we discuss in class, well, the AI suggested, the differential diagnosis is A, B, and C. Anyway, just thinking out loud. Because, I've seen experts who hate our expert systems, right? They purely hate them. They feel like they're going to take their job, et cetera, et cetera. So educating them to work with the systems would be really nice. I'm sure it's not new, but it would be.
That collaborative process more than AR, right? Why don't we squeeze in one key question from one of our postdocs, Francois?
Yep. So thank you so much. So one of the big challenges in medical education right now is like what William mentioned is like what we need to teach to our students changes every year, perhaps like even every month. And so some have suggested like, possible solution to address this challenge is like to teach more math, physics, or computer science, because the argument goes is like, this is less likely to change and perhaps this would, certainly remain relevant to whatever AI is. But this is very different to what is currently taught in medicine. So I was wondering, what were your thoughts on that?
I don't see the pre-med requirements changing in the immediate future. That hasn't changed in decades. That being said, many of our students at Stanford are opting into this content, and our students are also able to register for courses across the university. So going back to that, that reference to the 1.0, 2.0, 3.0 students, I can definitely envision that those students who are doing a scholarly concentration in this space or a PhD in this space will have prereqs that are very concrete in terms of the fundamentals of math, computer science, etc., physics, etc. Yeah.
I think it's pretty cool. If you want to speak to
Is the emphasis on education about AI, or is the emphasis on training how to use AI?
Both. I wouldn't say that it's an emphasis towards one or the other, it's that both are needed and neither exists. I think there's an assumption in these communities, that's what I've seen from my one-on-one conversation. There's an assumption that this content is already in front of our students. It's not.
No,
At all.
it's paying attention.
But we don't teach them like t-tests either, right?
At all.
We really teach them basic what is a
They
t-test.
just don't pay attention. What happens, what is and also what a lot of people here are doing like research, right? They want to invent new technologies.
Yes.
They gotta get their K or their R funded,
Yeah.
education, whatever. But actually, I think what's inspiring a lot of what I'm talking about is I think actually a lot of the cutting edge work in AI is actually in education. And actually the tools that educators use are how we're gonna actually build and use AI systems in advanced ways. So I think a really great opportunity to connect this whole community together.
Thank you.
Any last words from Dr. Thomas?
No, I just really appreciate the invitation and the opportunity to meet with you all. And my contact information is there. You could circulate the slides. Just please feel free to reach out if I can help in any way.
All
Thank
right,
you.
fantastic.